Thanks to our most recent panel. Thanks to all of you for all your contributions today and all your contributions over the last few months in planning this. I just, really more by way of helping me to remember, but also by way of stimulating your thinking, I'm sort of going through my notes for the day. Thinking back to our first session about sort of why are we here. What we heard very clearly was that traditional evidence generation using the sort of more traditional model of randomized trials is neither relevant nor sustainable, does not produce the answers that many people want, but also is far too costly. We heard, I thought, some interesting insights from Elliot about how could we make the process of evidence generation less expensive. And the note I wrote to myself was trying to make the knife sharper, meaning design manipulations, might save you about 5%. On the other hand, saying, I'd be willing to accept a much, much less expensive knife that cuts almost as well, could save you 60 or 70%. So I thought that was an interesting insight about which direction you'd want to go in terms of modifying methods. In our first sort of decision aid motivated session on data quality, I think what we heard was, this is a potentially useful scheme for sort of pinning down potential sources of error or slippage. How do we think about a clinical phenomenon making the transition from what exists in terms of a patient's body or in their mind to what ends up in a research database? But what we also heard was that the decision aid we have created is very much thinking about it from the data generator end. If one is a data producer or a data live wither, by that I mean I live with the data that I have, that's what I've got, you might need to think about a different way of assessing those questions going back upstream rather than going downstream. So that's a piece of homework for us to work on. We did one thing I wanted to go back to there that didn't get noted in the discussion, but I did sort of have a little sidebar discussion about it afterwards, was Luca's point about this idea about a data model and data digestion for the world of patient-generated health data. Why would you do that? And I think there's some interesting future work for us because in the traditional world where we thought about using discretized data that come out of insurance claims or electronic health records, discrete categories are the way we understand reality and even understand veracity or verify the quality of data. But when we're talking about patient-generated health data, remember the heat map that he showed us, the dimensionality of it is so great that the question is, why would you want to reduce that down? You would just lose information. That's going to be a real challenge because if we are trying to establish the veracity of high-dimensional data, that's something the human brain is going to have a hard time with. Then the session on blinding. The main note I wrote down was the one I asked in my question, saying, sounds to me like that panel was saying, these are really, really good questions. Good luck with answering them. And that is going to be a challenge. What we heard was both this tension between it matters how much. These are all potential sources of bias. We need to understand how big or important they are, but we cannot exactly put a number on that. So if you want to go back to my gumbo analogy from the morning, the gumbo recipe rule, when they say how long does it take to cook a roux, the answer is about 2 beers. And what that means is it depends. I did hear some important cautions, though, about 2 assumptions that I think we were coming into this meeting with and we may need to challenge. One is that there is a difference between so-called more subjective and objective outcome measures. Even those so-called objective and outcome measures, we can be fooled. Need to think carefully about that. And then the idea that preferences may be durable or that preferences may be something we need to respect because it's not quite as crisp as all of that. Then the last session talking about control or restricting treatments, I think heard some very useful information about the differences between the treatment protocol and the treatment setting and participants. Those are things we need to consider separately. There may be times when we say we may need to choose real-world treatment settings, we may need to enroll vulnerable participants, but that does not necessarily mean we need to have a very loose protocol. Those are independent decisions. Also heard, and this circles back to some of the issues in the session on data quality, that we may need to think about these loose loose versus tight issues differently if we're talking about a non-inferiority design. In a non-inferiority design, the noise biases you toward a finding of benefit or effectiveness. So that's a real problem that we have to think carefully about. And then in terms of our ethical obligations, an important point made about what are we risking, or what is the damage that could be done? That's quite different in a progressive disease where the consequence of low quality treatment might be irreversible versus a disease where the consequence of low quality treatment might be some reduction in quality of life, which is transient and completely reversible. So those might take us in very different directions in terms of the level of control. So that's sort of my summary. I'd encourage you all to be thinking about that. What we will do, where we go from here, if you thought that was fun, we're going to talk about observational comparisons and whether they are allowed or whether they are simply an abomination unto the Lord. That will set the tone for it will certainly be at that level that our discussion tomorrow, I am sure. We will begin tomorrow at 8, a little early, so we can try to get you out of here before noon. There'll be breakfast outside before 8, but we hope to see you all bright and early then. Thanks a lot.